So welcome to this community conversation / journal article conversation. We have some wonderful experts with us today and wanted to take a minute to introduce them. So first off, I'm Tanya Vishnevsky. I'm one of the co-chairs for the Just Medicine Committee, and I'm joined by Gretchen Buchanan, who's my other co-chair. So we have been running JMC and wanted to put out this conversation and just initial conversation about issues related to supporting LGBTQ plus folks, especially within behavioral medicine and integrated care. And we're hopeful that this is going to be one of several conversations, and some of the other special interest groups are going to also help host. So the next one hopefully will be from the primary care behavioral health special interest group, BCBHSIG. They'll be hosting one in the coming months, so look out for that. And we have with us Camille Evans. She has worked in healthcare and mental health over 15 years with a dedication to improving the care provided to vulnerable and marginalized people in the community. And through multiple roles within healthcare, Camille has worked to promote holistic and inclusive care, particularly in rural areas. And Camille has helped develop staff education and an increased access for LGBTQ affirmative care. Currently, Camille's helping to develop staff education. Currently, Camille works as the social services manager and behavioral health consultant for Valor Health, which is a small health system with a critical access hospital and outpatient clinics. So thanks, Camille, for joining us. And we are also joined by Quin Morrow, who is a doctoral candidate in the Family Social Sciences Department at the University of Minnesota. They study how transgender and gender diverse people resist gender-based oppression, and they're especially interested in how connection to community and close relationships can be affirming and healing for transgender people. And we also have Rachel Blanton, who's the Chief Officer of Innovation and Operations with Cornerstone Whole Health Organization. At CWHO, Rachel focuses on aligning community and clinical resources to better serve individuals, families, and neighborhoods in rural and marginalized settings. Ms. Blanton has a strong background in public health and healthcare administration. And she's coming to CWHO from Idaho, where she focused on healthcare innovation and a local public health as part of the statewide healthcare innovation plan. She's passionate about the opportunity to connect to organizations, community members, administrators, and clinicians as they all work to navigate healthcare transformation through local leadership, shared vision, and a dedication to community. So we have a wonderful group of panelists, and we wanted to now jump in with a summary of the article. And so don't worry if you haven't had a chance to read it, we'll give you the executive summary version. And throughout the conversation today, please jump in using the chat, or also you can unmute yourself anytime and ask questions and jump in. So I'm going to hand it over to Gretchen.
Thanks, Tanya. Hi, everyone. Welcome to our discussion. I'm just going to kind of give a brief overview of the article for those of you who haven't gotten a chance to read it. So this article was published in February of 2022. It was published in JAMA Psychiatry, and it looks at a cohort of 104 transgender or non-binary identifying youth about the ages of 13 to 20. And these youth were followed over the course of 12 months. They were in a gender affirming specialty clinic, and so they came into the clinic. They were provided a baseline assessment using the PHQ-9 and the GAD-7, in addition to a few other measures. And then through the 3 months, 6 months, and 12 months that they were followed, they also completed those assessments as well. Some of the interesting pieces that I saw from this were, end result was that gender affirming care improved rates of depression and especially rates of suicidality or self-harm. That was the most robust outcome, was reduced suicidality. What's interesting is that the anxiety levels were actually fairly unchanged. And because it was a GAD-7, we don't really know like what symptoms or etiology the anxieties had. We don't know, it didn't sound like they assessed for trauma or things like bullying or anything like that. And so there could have been, you know, some ongoing factors that contributed to the anxiety. Other things that I noticed, so the data were collected about 5 years ago in 2017 to 2018. And the environment has changed kind of significantly since then. So that was just something that I noticed, and I thought perhaps our panelists or anyone else would want to comment on what they're observing in terms of kind of the socio-political environment affecting patients that you're seeing or friends or family members, as the case may be. And then one other piece that I thought was probably important to discuss regarding the limitations is that they had a significant dropout rate at the 12-month mark. So they had started with 104. The 3-month and 6-month, they had 84 that they maintained in the study. And then that dropped out to 65 at the 12-month mark. They discuss in the article that they had to reapproach the patients to get consent to continue the study at the 12-month mark, and that's why a lot of people dropped out. So it doesn't sound like they necessarily dropped out of care, they just dropped out of the study, but we're not sure why that would be. And then one other final piece that I'll point out is that it didn't get a lot of airtime in the article, but substance use was pretty significantly affiliated with the mental health concerns, and then also resilience was measured, and it was also a significant protective factor. And so I thought that was also something to discuss, that we're not just talking about negative things, we're also talking about protective factors. And then because I have a family bent, and I also noticed that family support was strongly associated with symptoms as well. And they discussed in the article that they ended up adjusting for family support and receipt of mental health therapy. And so those kind of faded away out of the model. But I suspect that if they had analyzed this differently, then that might have been kind of a key point as well. So I will stop there. I'm curious to hear from our panelists what they thought of the article, how it fits with their personal lived experience, and also if you have any other articles or pieces of data that would be interesting for the audience.
I can go ahead and jump in and just say that, so Camille and I work together quite a bit, focused on gender affirming care in Idaho and in other rural states. And I would say that a lot of what's covered in the article resonates. Probably the biggest thing for me that sticks out is the political context, particularly now that we're in the middle of many state legislature sessions. So I don't think that you can separate this from what's happening in the politics of many states, particularly rural states across the country. So that really stands out. And you talked about family support. We think about community support. I'm really looking forward to hearing from Quin about their work in kind of those systems. I'll highlight, and I can put this in the chat in a moment, Camille and I reference the Family Acceptance Project quite a bit. So they talk about family systems and supporting particularly youth, and how that can be incredibly protective, but also how other systems within youth's interface with health systems and other community supports is so critical. So I think that that's absolutely important. In circling back to the idea of, oh, perfect. Thank you, Gretchen. Circling back to the idea of kind of the politics is, our observation is that family can be incredibly protective. It's also very challenging whether or not you have family support in the community context to feel and experience the hostility that happens for many individuals in terms of the politics, especially right now. So those are kind of my first observations.
So, oh, sorry, Camille, you want to go first?
Sure. I'll be kind of quick. I echo a lot of what Rachel said. So I'm in Idaho and provide mental health services and work a lot with the LGBTQ population. And I think I was just looking to see where exactly this was. It looks like it was mostly a rural area. So a lot of those external supports, especially in rural areas, are just very, very challenging. And the stress that some of the things that I'm seeing related to what Rachel was saying with the politics of what's happening is the stress that it not only puts on the individual, that child, but the whole family unit. In a lot of the families that I'm working with right now, and just looking at what's going on and potentially what that could mean for their child's care. It's a lot of stress, a lot of kind of questioning. Are we going to have to move out of the state, which is a big deal for a family. And so I think that the results of being able to provide the gender affirming care, I can definitely see in the patients that I work with, and that decrease in the depression, and in some cases the anxiety, but there, it feels many times like we are moving forward and then taking 2 steps back, especially in some of these states. And so I'm excited we're having this conversation.
So going off of what Camille and Rachel already sort of brought up, I wanted to talk about anxiety versus depression from a trans perspective. So I do a lot of research. Basically, all of my research is qualitative. Because I really want to understand what the thought processes are behind a lot of these patterns. I feel like we have lots of people doing really great quant work so far, but we don't always have good theory for why things are working out the way they do in the numbers. And so I really try to focus my work on trying to get some of those explanations. So some things that I'm seeing in a data set that I recently collected with 16 in-depth interviews with gender fluid people, and also in previous research that I've done, is that so getting access to gender affirming care, like medical care, like what we saw in this article, is really associated with hopelessness. Because so gender dysphoria, people have different experiences of gender dysphoria, but the experience of it is very, it can feel very disassociative from your body. It can be very difficult to imagine a future for yourself if you don't feel any connection to your body. Right. So not having access to transition, not just medical care, but also social transition, really can cause feelings of hopelessness and depression. But anxiety, I think, my theory right now, is that anxiety is more tied to transphobic environments. So by allowing people access to transition care, you can help with some of that personal hopelessness. You can help people get access to a future that they can actually see themselves living in. But as long as the socio-political environment, as long as the society that they're living in is fundamentally transphobic, there's always the fear that that future could get ripped away at any moment. Because if the laws change, if you lose access to your health insurance, suddenly you don't have that transition anymore. You don't have that care anymore. You don't get that future. And so even if you've been able to transition, you're living exactly the life you want to live, you constantly have to worry about that being taken away. And so I don't think we're going to see an effect on anxiety until we change the socio-political environment. The other thing that I wanted to bring up, just part of this conversation, because this is something that I've been talking about a lot with my own work as well, is the current political environment is very scary. But I think it's important to keep in mind that it's not actually that different from how things used to be. The difference is that historically, there wasn't any need to legislate these things because families and communities were already doing this prejudice on their own. The big change that we're seeing is communities and doctors and families are beginning to become more accepting. So you have this group of people who have very much bought into transphobic rhetoric, who see that as a threat and are now trying to legislate that support out of existence. So like most of my work is actually with trans people who don't have any affirming family. And so they would never be able to even get access to this clinic to gain any sort of care until they were adults and were separate from their family. Because in order to gain access to gender affirming care as a minor, you need guardian consent. And so the young people I work with don't have guardian consent the vast majority of the time. So I also think it's important to keep in mind that when we're looking at these clinical samples, we're actually looking at a privileged group of trans people. And that we shouldn't expect to see all of these same dynamics. And well, two things. We shouldn't expect to see all these same dynamics necessarily in a community, in a broader community sample. And also, even for the most privileged of trans people, it is still rough, is kind of the other thing to keep in mind. And I'm going to pause there.
Quinn, I just want to say what excellent points. I love what you were saying.
And please jump in, everybody else here with questions. And we're already getting some wonderful questions and comments in the chat that I wanted to highlight in a minute. Just my reaction to what's said so far. Quinn, first of all, I'm really intrigued by your hypothesis. I think it's a really good one. And I wonder how the data and the qualitative data are going to play out over the next year or two as the socio-political climate has worsened, and how that might reflect more anxiety in the general LGBTQ plus population, and how this is going to affect trans folks in particular. So we'll see how that plays out. I wanted to also just kind of read the comment from Liz Foxley, because it's very, like, it just hit me when I read it, right? I live in Utah and I had a patient who was just started on HRT as the bill was being passed, banning gender affirming care for minors, which led to the admission to our local mental health institution for SI, and how this has impacted that spike in suicidality and suicidal behavior in gender diverse youth. I wonder what others have experienced in their own clinics and just clinical settings. Have you seen that spike in SI?
I also just wanted to talk or kind of reflect a little bit on that notion more in detail about the anxiety versus depression piece. And I'm wondering, in terms of the clinical application, since I'm assuming that most people on this call are probably clinicians in a primary care setting, how, if anyone who's been working clinically has seen that distinction, and how are you really working to address those different pieces of the mental health of the patients that you work with? Kind of recognizing almost the futility, not futility, hopefully not forever, but of trying to treat away anxiety that's really valid and isn't going to go away until the socio-political environment changes.
So I'm in Emmett, which is about 30 miles outside of Boise, so kind of rural area. And what I have noticed is just being having a focus on changing the kind of the environment that patients have access to by creating a more inclusive environment, asking the right questions in a affirming way, and just kind of opening the door that we, at first, when I started doing this work, I had a lot of providers who told me, like, this doesn't, I don't know why we need to focus on this. We don't really have anybody who fits into this population in our community. And that has quickly became apparent that that is not true. Just by doing some what feels like very simple things. There's so many other things I would love to be able to do. But you have to start where we can, especially in the more conservative and political environments that we're in. And sometimes getting some pushback. Just recently had some pushback from one of the providers about the way we were asking some questions on our intake form. This provider wanted them completely removed, and, you know, having to just kind of stand up and say, no, we won't, and come up with somewhat of a compromise. And, but being able to do those things has made a huge difference in patients just feeling like it's safe, that this is a safe place for them to be able to talk about what's going on, talk about how they are doing with everything that's happening, and with their own stuff, that, you know, that kids have a safe place to come if they don't feel like they have that family support, and that parents have a place to come and ask questions, because especially in an environment like this, there is very limited support for parents that are trying to figure out how to navigate this. And I think many times we forget the importance of teaching parents how to navigate, which is part of what I love about the Family Acceptance Project, and that they take a kind of conservative role or position, and have kind of different routes and address the religious aspects for a lot of families of how to navigate this. So by doing those things, I think we start to reduce some of that anxiety that there isn't supports out there, that they're kind of having to figure out this alone. But I agree with what Quinn was saying, that until the environment changes, I think we just have to teach people how to manage that anxiety, and how to find the right supports within the limitations of the community that they're in. The online stuff is excellent. I have personally, as a parent, I have 2 queer children, and it was like 14 years ago that my daughter came out, and there was nothing out there then. Like, I lived in this community that whole time, and there was nothing definitely in the community. There still is nothing in the community, but there was not the online stuff either. And so, I think the more that we can educate whole families and build those natural supports, the more that we can help people in the midst of all the political stuff that we're dealing with.
And I just saw a question in the chat regarding systemic change, and I can't say that we've worked in the Bible Belt, but we've worked in rural Idaho, which I think that we've got some similar context in terms of religious and political influence. So I'll put in the chat some of the work that we've done. Camille has been an incredible leader in this space. 4 or 5 years ago, we went after a funding opportunity to essentially ask the question, what does implementing an affirming care practice look like in rural and conservative communities? So I'll chat in a link to some of what we've done. But I think that Camille has done a great job of kind of summarizing some of that. And you kind of get deeper into the levels as healthcare providers. It's like, first, that visibility component, absolutely right. I'm sure that many people have had that experience with the providers that they work with and your colleagues of saying, hey, this is an important issue. And people saying, those aren't my patients. And we know that that's not true, but you have to do that first step, like peeling back the onion, right? And then, some of those basics of affirming language, like what why pronouns are important. You know, how do you talk about gender identity and sexual health and sexual practice in a way that affirms somebody's identity and isn't disrespectful? And then getting deeper into like, okay, what changes do you make in your EHR? What changes do you make in terms of staff training? And so I think that you can go into those steps if you're looking at taking a systems approach to making some of these changes. And that's, again, some of what Valor and Camille have done. The other thing that I would really encourage, particularly from the primary care side, is there's, I don't want to misstate this, but we've almost found this like underground network of providers, like primary care providers, and then referral resources that just tapping into that network. So finding other providers that are aligned and are practicing, you know, recommended clinical services for this community. And we've had to have some really tough conversations as a group about what that means, like whether or not it makes more sense to be a loud advocate or to fly under the radar to get some of the work done and some of the care services delivered. And, you know, honestly, right now we're tapping into those networks quietly so that we can help connect patients to care. And it's something that we felt conflicted about for a long time, but that's kind of where we are. And that's the decision that we've made as an organization. So anyways, I'll chat in that link for some of the resources that we put together. We've actually got like a roadmap document, which is intended to help guide other organizations through that process. But yeah, that's kind of my first reaction to your question, Shannon. Thank you.
Yeah, and Shannon, I'll add some of my experience. So like I said, very conservative area here. And I have very much taken the approach when it comes to like talking to administration and stuff, that it's important for us to create a safe environment for everyone, and that it's about treating people with kindness. It's really hard for someone to argue that, to say, no, we don't really want to be kind. And so, I mean, it seems simple, but that's kind of where I keep just bringing any argument back to. And then there's all these lists out there. And when I first started, I got these lists that said, these are all the things that you need to do to become an inclusive organization, to provide inclusive care. And it was daunting because there were so many things that I'm like, that is not going to happen here, at least not for a very, very long time. And so I had to recognize that I need to start where I can start. And so worked really hard to get SOGI questions on our intake paperwork, did education with staff, had to kind of learn some different ways to make that doable. And, you know, and then this was also like all through COVID that a lot of the work we were doing was, and so had to go to just doing a lot of recorded trainings for staff. And so that as we had turnover and stuff that it's just part of what we do. And there is still a lot of work that we have to do. But I think that it's become just kind of part of how we do what we do. There's a lot of things that also help, like we are a patient-centered medical home. And so as requirements for that, they're starting to add like in this annual review, one of the questions is that we have a way to be able to designate gender identity and pronouns and those kinds of things. And so if you look for some of the regulatory requirements, that also can kind of build a case for, we need to do this. And getting administration on board and starting where you can, I think is hard, but that's really where you need to start. And then finding just a couple of those champion physicians who are going to have your back, and they're going to help you push the importance of this. And then there's going to be a couple that are going to be a challenge, and you just kind of have to, you know, sometimes I close the door and I vent to somebody who's safe, but then just, you know, keep plugging forward. I always remember that even though sometimes I feel very isolated and I feel very much like I'm kind of alone in trying to do this, that's minimal compared to what someone who is struggling with being able to access the services they need and get the support that they need experiences. And so it kind of keeps me fighting the battle and making the small changes. We don't have stuff in our lobby that shows same gender couples or, or even a flag or anything, thing in our lobby. We're not there yet. I have it in my office. But I just, you have to start where you can. And I've yet to have anybody tell me to take down, my little flag or anything. There's a few patients who may not want to see me. I'm okay with that. If, I just have decided I have to be okay with that.
I think, and I'm in Oklahoma, and we're, unfortunately, the state is leaning towards banning affirmative care as well. I think as a leader, when I think of all the layers of things that you guys are discussing, which is really helpful, I'm in a tribal system, which historically with Two-Spirit and individuals is very tribal friendly, but in a very conservative political state. And so my greatest anxiety is that the patients that we have, it's kind of a lottery of what provider they're going to get when they come here, like what pediatrician, what therapist, et cetera, et cetera. And within every single team, the provider team, the nurse team, the therapist team, the psychiatrist team, the psychologist team, there's so many individuals with so many different beliefs, and the burden of bringing everybody to consensus feels overwhelming, and also the burden that patients will feel rejected and not welcome here. So as a leader of those teams, and moving people that are very rigid politically, so much so that they say, I don't want to work with these populations and things like that, it's just very overwhelming as a leadership, not only to manage the team under me appropriately, but also to influence change in the leadership above. And so it feels very daunting in Oklahoma to have this conversation.
I just wanted to add something, because we brought up family acceptance projects so far, and we're talking about, I'm originally from Texas, and I was a caseworker down there, a nonprofit, before I came to grad school. So I'm kind of familiar with working a little bit in that space differently than I am now. But so Family Acceptance Project, I think, does a lot of really good work. But one caution I wanted to bring up and related to that particular program is that particularly when working with religious families, they can sometimes suggest that you can take kind of you don't have to accept your child's lifestyle, but you do have to accept your child approach. Basically trying to assure religious parents that they don't have to give up their religious practices in order to affirm their child is the goal. And I wanted to bring up an article, which I'm gonna post in the chat. And this is directed at clinicians, but is kind of addressing a very similar thing, where there is a limit to that and how affirming that approach can be. So that can be a good starting point, but it probably isn't where you need to end if you are really trying to move towards an affirming practice, because queerness is a part of who you are. And so somebody saying, I love you, but I don't love this central component of who you are as a person, and I don't accept that, doesn't feel like acceptance when it's experienced by you. So I just wanted to include this article as like a little caveat, because it's like a slight disagreement I have with some of the Family Acceptance Project's approach. I actually, when I was doing my advocacy work, and like your mileage may vary, but for me, I found it sometimes much more helpful to just be really honest about the fact that I was actually asking them to rethink some of their value system. And what I would do is I would look for other areas of common ground on value systems. Like Camille brought up being kind. That can be a great place to start, right? That's a value that you can share, that you can focus on, instead of focusing on maybe some other values that maybe aren't helpful, right? Like conservative, mainstream gender norms. right? That might be a value that the person you're talking to holds that you're going to have to find a way to break down in order for them to really be affirming and supportive of a trans person. And this is more like my experience isn't so much from an institutional standpoint, it's more on a one-on-one standpoint, like working immediately with families. So that's why I say your mileage may vary, but sometimes I found that just being honest about the fact that I was making a big ask, but that I was going to make it anyways, I found was actually helpful. People seem to occasionally, like depending on the person, feel it out, but sometimes people seem to approach that bluntness or appreciate that bluntness rather than pretending like you're not actually asking them to do something when they feel like you're asking them to do a big thing.
Quinn, I appreciate that. And I think when kind of taking that approach that you had talked about, that the Family Acceptance Project has kind of talked to, I see it, and I wonder if you would agree to this, as kind of just a harm reduction approach, that if that's where we have to start, I'll start there. But I like your point to saying I'm gonna ask you to do some hard things here. I'm gonna ask you to kind of question and reevaluate some of what you may have always thought. I think but sometimes we can't start there. And so I think the two that I probably use the most is the Trevor Project, and then if I have a very conservative family, starting with the Family Acceptance Project, because I have found if I start somewhere else, they just shut me down and won't even bring the kid back.
Yeah, and I want to thank Quinn. I appreciate you bringing that up, and agree with Camille on kind of the harm reduction approach. And again, going back to thinking about the systems that people are in, when Camille and I did some focus grouping, and so this isn't, peer reviewed research, but, when we started to gather some data related to our approach within Camille's community, we asked people about their general experience, and, surprised to not many, to none, a lot of people, and particularly youth, mentioned faith communities as a significant source of stress and rejection. And so I think that that's just something to be aware of. And I think that faith communities, of course, we all know this, can be incredibly supportive, but they can also be sources of incredible stress and rejection again. So, and I think particularly for this patient community, this group of individuals that we're looking to serve, I think that can be incredibly fraught. And then when you zoom back out to the patient's family, Quinn, to your point, there's kind of a ceiling on that, right? So if you've had this relationship with your family's faith community that's so rejecting, there's that ceiling to how much your parents or your caregiver or your family can say, I accept you, but right. So I think that's something that we've definitely found just in conversations, particularly within the community where we work.
One other thing I wanted to add real quick while we're thinking about trying to work in spaces that are generally conservative is do your very best not to make promises you can't keep. So the reality of being a trans person, part of that resiliency component that the journal article brought up, is learning how to navigate gender in different spaces in order to protect yourself. And so if you know that there are certain things that you're going to be able to do to support this client, but there are other things that you can't promise that you're going to be able to do, make sure that you're really honest about what that is, so that the client that you're trying to work with can make decisions for themselves about how much risk they're willing to take with their own safety. Because it can be far more hurtful when you go into a space, you were told it was going to be safe by somebody who probably had the best of intentions, and then you find out further down the road that actually that space isn't safe for you. And looking back, maybe you wish you had been a bit more conservative in your approach. That's something that came up a lot in the interviews I did recently. We had an entire section about experiences in medical care. And a lot of people were talking about like very well-meaning providers who basically promised more than they were actually able to provide. So I'm not saying don't try. And this is so hard. This is so hard. I totally want to validate that this is so hard. Because the other side of this is you can be too conservative and then you don't take any risks and then nothing ever gets better, right? So it's like, it's a very challenging balance. But try to be really honest with yourself and with your client about what you can and cannot promise.
So I have a general question, probably for Camille, but maybe for others as well. And this, so Quin, what you were talking about brought me back to Shannon's point earlier with being in a particularly conservative state or in an environment, especially providing medical care for trans folks and LGBTQ folks, where it's not always very affirming. I wonder about your experience with, what are the first little seeds that starts the shift in culture in a medical setting to be able to do some of that? I mean, it's Rachel and Camille, you talked about that and having some of these pretty big successes, in my opinion, from your experience. Are there kind of, like the big takeaways of, oh, I definitely like this was a really good first step, or this is what I would suggest others to do?
Yeah, I think definitely taking a look at your intake paperwork and making sure that you have affirming questions and opportunities for people to use preferred names and to list their pronouns, and that you have a way to flag that in your medical records, so that when they come, the correct names being used, and then when you start talking about pronouns, it starts kind of opening the door to helping people to understand the importance of using the correct pronouns. The other thing that we started early on with is focusing on taking sexual history. And so that mostly was around the providers and the clinical assistants, and did a lot of training about why we take a sexual history, which doesn't necessarily just involve LGBTQ issues. It's just sexual history. Sex is part of, our experience as humans, and it should be part of medical care and the questions asked, but something we many times people might feel uncomfortable about. So I don't have the study right here, but in the education I did, I had found some studies that showed that providers, their feeling of how uncomfortable a patient would be was significantly higher than the patient actually being uncomfortable with the questions. So I think we get that fear gets in the way of asking the important questions that do impact the care that someone might need. And so we focused on that sexual history and just kind of seeing like the whole person, and help them with ways to ask the questions. The CDC has the 5 Ps, which was what we kind of used as a guide point in how to start, what are the things you need to focus on, and how do you ask some of those questions. And so that's kind of where it started. And then I tried to just do some kind of fun things, like during Pride Month, I did an LGBTQ language bingo for the whole organization, and whoever wanted to participate could participate. In hindsight, it was a really good way to kind of find out who my supporters were. And because those were the people who wanted to participate or said, thank you for doing this. This means a lot, which they probably wouldn't have told me otherwise. Because they were people I may not interact with a whole lot. So just kind of some different things like that. I gave then everybody these like rainbow pins, and now a whole bunch of staff who participated. So they have some level of wanting to work with this population and acceptance, have pins on their badges. So they're like silly, little small things, but they have made a big difference.
And I'll say, Camille's done amazing work on this. I'll say a couple of places. Another learning point, right, is where if we went back and did it again, what would we do differently? I think that 6 to 9 months into the project, we're like, man, we're having a hard time getting traction. People, and this is for all training, especially in the middle of COVID, right? That we surveyed them and we were like, how much training have you had? And they were like, none. And we're like, but we gave you hours of training 2 months ago. But anyways, so we're like, all right, we actually need to talk with our providers, our clinicians, and the rest of the care team about where they are with their attitudes, values, and practices. And so that's something I wish we would have started with. I think it all ended up okay, but I also think that it's relatively easy to go into this work pretty, not with blinders on, but pretty entrenched in like, okay, this is the path forward. This is what we're going to do. This is our timeline. It's non-negotiable. And I don't want to negotiate away the work that we're doing. It's just like really important to contextualize that. Like we had clinicians that told us some pretty hurtful, hostile things about their attitudes with, working with this population. And I think it reminded Camille and I, like, okay, 3 steps back. We had some conversations around like, maybe we're not going to change their attitudes. Maybe we just need to change the system so that it's a lot harder for either patients to meet that hostility, or that they're in some ways forced to at least recognize and provide care in a more affirming way. And so I think that was a big thing that I felt like I learned that I would advise other people to do differently, is to maybe start with some of those care team attitudes. It doesn't have to be a survey. Whatever you feel most comfortable with in your system, start to have some of those conversations to take the temperature of where people are. Because I think that really would have changed some of the initial work that we did in terms of engaging or really thinking about like what our timeline was to make some of these changes.
I feel like there's been a whole lot of really great information shared today. I was wondering, Quinn, if maybe we could go back to the resilience piece a little more, and if you've found in your work other pieces that might be useful for clinicians to think about when they're working with this population, in terms of being able to kind of build resilience or contribute to it in some way.
Yeah, so a couple of really common resiliency factors that come up. Chosen family is the big thing that comes up really consistently in my work. So we were talking about the importance of family support, but keep in mind, family isn't always necessarily who you're related to. Particularly for trans people, romantic partnerships tend to be a really big deal, at least in the research that I've done. People will oftentimes bring up specifically the support that a partner gives them and how validating and important that can be. And I think it's because it becomes such a significant attachment relationship for adults that can, if you maybe don't have the greatest attachment relationship going on with your parents, which is the other significant attachment relationship that a lot of people have, a really good, solid partnership with somebody who's supportive of you can help a lot. So from the standpoint of chosen family, I think mainly from the perspective of working with therapists, because those are all the people in my department. And so I think more from that perspective, they're really just validating that those connections are important. Also, I think even as a primary care provider, you might be able to ask about those relationships if it was like, if you're asking people to think about who their support system is, maybe if they're trying to access treatment or something like that, making sure that when you're thinking about how you're asking those questions, you're leaving room for people who aren't necessarily the relationships that you might expect in those circumstances can help. I'm trying to think about other things that connection to queer community is also a big deal. This is something else. Actually, this is a good point. So something that came up recently, again, in those interviews talking about medical experiences, even not so great clinicians oftentimes suggested that clients connect to a trans affirming support group. So the clinician maybe didn't hit the mark, but because that person had access to a trans affirming support group of other trans people, they ended up getting a lot of benefit. So that's something that I think might be sellable even to maybe clinicians who aren't fully on board with the whole idea. If you just say, hey, if you have like a trans person, just connect them to this group that we know is like a good solid support group for trans people. That was so like I was talking to one participant who was talking about a clinician who denied them access to HRT, right? So like big clinician problem, right? But still suggested that they go to this trans affirming support group. And in the trans affirming support group, they got a suggestion from one of the other members of the group of an affirming clinician they could go to get HRT. So that might be a more roundabout way of doing it that maybe feels a little bit less scary, even for people who aren't so bought in yet. Partially because sometimes clinicians will use that as like almost a gatekeeper or a gatekeeping point where they'll say, we won't give you services until you join this group. So that can be a good way to connect people to services. Those are the first things that come to mind. Gretchen, I know that earlier you brought up the substance abuse piece, and that's been more of your focus in your research. I'm wondering if you had any thoughts about that piece of the article, because the article didn't dig into it at all. I'm wondering if you have any thoughts about how we might address that bit.
Yeah, I mean, I think with regard to, substance use, especially in the young, the teen and young adult population, is, there's a lot of different reasons why kids use, but when it becomes problematic, often it's because they're using it as a coping mechanism, and that could be also related to like the self-harm and suicidality that was discussed in the article. So, you can kind of see that hopelessness that you talked about a lot, Quinn, and the anxiety, and those could be contributing to the substance misuse. And so if you're addressing those pieces, not to say that you shouldn't be necessarily addressing the substance abuse piece, but looking at those kind of contributing factors, those emotional contributing factors, and addressing the hopelessness will often lead to a reduction in the maladaptive coping mechanisms, which would include substance use.
And am I remembering the results of the study? So I know that they mentioned that substance use was the only variable that was associated with all other variables, right? But substance use didn't change over the course of those 12 months, right? That gender affirming care did not necessarily reduce substance use. Am I remembering that correctly?
I don't think they were powered enough to really be able to detect any changes, because not all the participants were using, and then they had such a drop off. I'm not sure that they would have been able to detect if there was a change. There is another question in the chat as well, and I'm mindful that we're got about 4 minutes left. Any resources for young adults who have come out and found no support from parents? Have found more resources directed to youth, but just curious about young adults as well. I think that's often a group that kind of gets skipped over, right? Like, oh, you're an adult now, but they're not quite, like when you're 18 to 21 or 23 even, still often very dependent on parents and parental financial support, and to suddenly not have that could be significant.
I kind of address that. I think it kind of comes back to what Quinn was saying about those external supports, the kind of family by choice that people create. And in the area I work in, because unless you go over to Boise, which 45 minutes to an hour away, there are no support groups. And so what I find them most of the time using is online and through gaming. That's probably like having a gaming community of accepting and kind of, they may not know them face to face, they may not have, but they interact with them on a daily basis. and that kind of becomes their support group. And so that's just kind of, I think, what a lot of people have had to reach out to when it's not in their community, but probably even when it is, that is also happening. And so helping people to explore the support they find in this, and just recognizing that for some people that is the primary support that they identify with. Very different from how a lot of us, I think, look at building the support networks, but for some of them it can be very beneficial.
Well, I think we should probably wrap up, because I'm seeing most people are probably dropping off because they have 1 o'clock patients. So I just want to say again, thank you so much to Quinn and Rachel and Camille for your time today and your resources and your brains and the work that you're doing. So thank you again so much. Anybody who had any further questions, you can always email Tanya or myself. We're happy to pass those along.
And if there's other resources and articles that we get, we'll share them. We'll post them on CFHA listserv so that you all have access to it. And be on the lookout for the next series and these conversations. And thank you so much for our panelists and those of you who were able to join today. Thank you.
Thank you.
Thank you.